Okay, good afternoon. So, I'll be talking about breaking down barriers in healthcare in Nigeria, or basically just educating you mostly about how healthcare is in Nigeria and my experience so far. So, Nigeria. So I decided to put a bit of geography so that people that may not be familiar with where we are located on the continent of Africa. That's where we are. And yesterday somebody was asking me about size in relation to Texas, and I was like, maybe it would be nice to get a relationship to how the size compared to one of the states in the United States. So I checked it up, and apparently we are 6 times the size of Georgia and slightly 2x of California. I don't know how big that is, but yeah. Well, our health indices are pretty ridiculous anyways by the looks of it. They said we had a maternal mortality rate of 576 as at we have a national demographic, research, and they do that. They said it was 576, but recently I checked, is at 814 per 100,000 live births, and our live births that's 32. Okay, MMR is related to anything 6 weeks post delivery and from 28 weeks, or anything related to pregnancy. And then our infant mortality rate is at 69.8 to 1,000 live births. So let's say 1 in 100 children die, and then 1 in 5 children die before the age of 5. So that's our under 5 mortality rate. And yeah, our indices is if a child is only up to 32 weeks, so we only count children that were born after 32 weeks. So if you have any live birth less than 32 weeks, it's not viable, so it's not a live birth. Okay. And then our government expenditure has continued to dwindle in health care. At 2012, it was 5.95. That was the highest since, well, I would say our politicians love to do a lot of they love oratory. So they come out and say a lot of, fancy things. They go for conferences and say, oh, you know what? We are Nigeria. We have a booming oil economy because, we rely mostly on oil. We are going to give 15% to healthcare. And since that conference, that was as far back as 2000 or 2002, where they were like, we are going to give 15, we've only been, highest has always been 5.95. This year was 3.9% of the entire budget for health. Well, there are smaller countries like Rwanda that are doing way better than us, and they got over the genocide like how many years ago? Just like maybe 10 years, still fresh, and they are doing way better. Well, talking about our diversity, I'm from the Yoruba tribe. It's like southwest down, yeah. So that's where I come from. I'm from Oyo State, and though we are a very diverse, group of people, we do try to, come together and say, yes, we are one Nigeria. We want to have similar goals, but we are still trying to find our footing as pertains to that. And as relates to healthcare, you realize that a lot of our cultural differences and values actually affect our health-seeking behaviors and, health lifestyles in general. So this is me, Zainab, and Ekene. I started this journey in 2014 when I started talking to Beth. As at that time, so med school is an undergraduate degree. We do 6 years. So I finished from secondary school, that's high school, and then I couldn't get into med school the first year because it's so competitive. That's why we have like so many people going out. If you have the money, you take your money elsewhere. You take your money to the US, Ukraine, Caribbeans, and go and do medicine there because you have the money. If you don't have the money, you have to keep reapplying and, doing the cycle. So I was fortunate. I was able to get into one of good coaching schools, and I got into med school. There I met Ekene and Zainab, and in 2014 we had this really long strike that I didn't know when it was going to end. It started and it was like they'll call us back 1 week, 2 weeks, 3 weeks, 1 month, 2 months, 3 months. It ended up being 6 months out of school, not knowing what I was going to do. I was frustrated. I was like, do I have only med school to look forward to? I have to know more, like find something else to do. So a friend of mine introduced me to BRI. I started talking to Beth, and I admit, I didn't immediately give me a contact. I wasn't sure if I wanted to reach out because I was, the whole Nigeria full of, 419 scams and, I actually was like, would she even think, I was very surprised at the speed she replied my emails. I was like, huh? Is that no, I was like, wow, that's like someone really trusting, like just believing that, there's still some good in there. So, yeah, I started BRI, trying to talk to people, and then, though back home, when people ask me, isn't this group like, aren't they against everything we hear about, talking about, we only hear the side where, it's good to have health insurance. Now, like our insurance scheme is at 9%, and it's obligatory for all federal government workers to be covered by health insurance. Every other person is not on health insurance. We have, like, out of pocket is about 6 to 70%. So you have people paying out of pocket for their health financing. That is not the problem. The problem is the finance. Because you have a country where 60% or more of the people are living in abject poverty. It's not exactly easy for them to pay out of pocket, and a lot of them run bankrupt trying to pay for their out of pocket expenses. So if learning, learning in school, because our education is actually all inclusive. We have training on how to run a small medical practice. We have all that training about, because we are allowed to own our own practices and clinics and hospitals, but we're not allowed to advertise like over here. So the problem is, how do you don't get people mixed up, so you don't sell them something that it's not like, because you have people coming in and saying, yeah, insurance is good, they should do this, but they don't even know what and then Nigerian people, because of the cultural ways, we don't actually believe in putting money into something we are not seeing the result immediately. So putting money away to someone, and it's not my savings account, and just hoping that one day I'll fall sick, it's like you are putting a curse on me, so you want me to fall sick, huh? That's so it's not easy to sell insurance. So that now brings us to the community-based health insurance scheme. So they try to do something where a group of people, so if we are farmers, we come together, we have a farmers association, and then you people put money together, and then you decide that, okay, we'll pay maybe 30 cents, so that's 100 naira. I think that should be affordable for most Nigerians, but it's 100 naira per day or 100 naira per month. And then the government deeply subsidizes like 90%, because what they are doing now is like government gives 80%, and then if you are employed, employer gives like 5 to 10%, and then you give the other 10%. But is that really sustainable on when the government is only giving 3.9% of the annual budget to health? And about what they are not telling you is that about that 3.9%, about 60 to 80% of that is on reoccurring costs. That's cost of paying health workers, keeping the hospital running. So you only have about 20% of that, or little or more or less, going into actually infrastructure of healthcare, or doing new things, or paying for stuff like health insurance. And then also other sources of funding for healthcare, we have private insurance, which only the rich or middle class can afford. And then the rich definitely won't stay in Nigeria to access healthcare. A lot of them, we love medical tourism in Nigeria. It's like, we have this company, Flying Doctors, wonderful innovation. So she finished from the UK, and then she came to Lagos, and then if you have your money, she flies you out to London or to wherever, UAE, to the US with a jet or an helicopter. So you have these really big politicians and businessmen, you know, being flown out. They can afford it, which is, and then so they tax large luxury goods and harmful commodities like cigarettes. So cigarette is highly taxed, but still cheap. You can get a pack of 100 packs of that for about maybe $10. Still ridiculously cheap. And then the state, because the state doesn't opt into the national health insurance scheme. You know, it's only obligatory on federal government workers. The states have to come up with their own. So we have states like Oyo State, Lagos State coming up with their own form of. So we have Aishat, that's Oyo State Health Insurance Agency. So they came up, and I remember I went for that meeting, and then they gave about, they were trying to make up considerations about how much to let people pay for a bronze, diamond. They were shot platinum and gold, the kind of, you know, businessman. They were like, okay, basic 750 naira you have to pay, which is about $2 or $2.50 per month. Was it per month or per day? I wasn't exact. I can't remember. Okay, so this is where I work. I finished last year, and it's a hassle because, you know, as with my country, I won't say for most, but as with my country, nepotism is it's deeply rooted. And it was a hassle to really get my job here, but, you know, I had to, I have a license that reads for 1 year. It's a provisional license. So if you don't get a job within 1 year, you have to write the exam all over again. So yeah, my mom had to get me the job. So current rotation, I'm going through the pediatric end, and what I noticed is as with public hospitals, the government funds everything. It's actually absurd for you to say that I want to, okay, for instance now, random blood glucose. They don't have strips. The government hasn't provided strips in a week. And you have children, you need to check their random glucose, because most people usually wait until the far end. They see the child almost lifeless before, and then they'll come and say silly things like, she was eating this morning. Actually, a lot of stories are actually very, you know, blurred up when they come to the ER. And then you want to check, and then you can't. And then you say, okay, can I go and buy one? Like that's like the AccuCheck, which has like 100 strips, and then because it costs 6,000 naira, which is maybe $20, and then say that, okay, why not I sell one strip, so like you pay 200 naira to get a test done. They're like, no, you can't do that. If you accept money, they can call you for a, like, you know, this round table, so you get the talk. If you actually, you know, think of stuff like that. And then the pharmacy is almost always empty because they don't have what you need. There's no supply, and then you force people to buy, and then because people have generally over time developed a kind of, you know, entitlement mentality, like, you know, the government has to empower me, the government has to do this for me, the government has to treat my kid for free. So they're like, do I really have to buy? Do I really have to pay anything? So what are the barriers I've identified over time? Mindset and education. So I feel like I've noticed that because of the educational barrier, not many people are educated about health. And then the way we practice healthcare in medicine is like, we already think about it, and then you come to the ER and you're like, okay, you have cough, you have fever. Listen to your chest, okay, crepitations all over. You have a pneumonia, I give you drugs. And I'm not actually talking to the patient to explain whatever it is, or so it's like I can see close to 30, 40 patients in more than like in 6 hours, and just keep going, keep going. Especially on a 24-hour shift, you see a lot of them at the pediatric hospital. They just keep coming in. So a lot of other problems, cultural issues, especially up north. These northerners are very, very patriarchal, you know. Their wives can't come into the hospital if they are not there. They are not going to see a male OB. They are not going to, you know, let them come for vaccinations. There are a lot of, and that's where you have most of the troubles with the Boko Haram and the kidnappings and all that. And then also the lack of basic amenities. There's not much to give. And crisis, and then most importantly, corruption. So over time, what solutions have I started thinking about? Because, you know, the solution that most of my colleagues, when they took the poll at graduation, I know the question is, how many of you are going to leave the country to go for residency? And like, see people are leaving. Everybody wants to leave because it's a horrible situation. People are, and again, the environment is hostile. You have this, you know, antagonist group of, you know, allied health workers, the JOSU, they, you know, they're like, you have the nurses, pharmacists, every other person aside from the doctor, you know, like, doctors are evil people and all that. So the environment is hostile, and people, and doctors that just want to have a quiet practice and do their job and get paid and enjoy their life find it very, you know, it's a lot of bad energy, so they want to get out of that easily. So the first thing is, you know, we need to educate people. We need to educate, we need to educate and then also seek into innovation. So start thinking about practice and how, so that's how Benjamin Rush comes into my own, you know, looking at ways I can help solve the problem. And I'm open to suggestions. I've seen a lot of wonderful ideas since I joined the Benjamin Rush, and I'm hoping to infuse that into my practice soon, towards the end of this year. My conclusion, the best place to be for me is Nigeria, in Africa. And it starts with seeing the big picture, because it's seeing beyond just my generation and seeing the potential that, you know, staying to solve the problem will do. And I'm really grateful to BRI for the opportunity. Thank you, guys. Yeah.